Imagine hearing that a disease can persuade your own defenses to stand aside. Not by overpowering them, but by convincing them that nothing is wrong. That is the unsettling truth about prostate cancer. It doesn't merely grow. It learns to interact with the immune system in ways that keep it safe. The good news is that scientists are beginning to understand these interactions in practical detail, and that knowledge is opening the door to treatments that make the immune system effective again. Stay with this to the end. Clarity about how this works can change the way we think about treatment decisions. If this kind of clear health information matters to you, tap like and share this video with one person who needs straightforward science. It helps the message reach others who are searching for answers. Prostate cancer begins in the prostate gland, a small organ that helps produce seminal fluid. Many tumors grow slowly and remain localized for years, but some become aggressive, spreading beyond the gland into nearby tissue and, eventually, to distant organs. Early disease may produce minimal symptoms, which is why routine screening discussions with clinicians are important for those at risk. When cancer advances, treatment decisions can involve difficult trade-offs among surgery, radiation, hormone therapy, chemotherapy, and newer biological approaches. Each has a place, each has limitations. The immune system, if properly engaged, offers a different path, a targeted, internal response with the potential to be both precise and durable. To understand why this has been challenging, it helps to remember how immunity normally works. Your immune system relies on recognition. Cells display small protein fragments at their surface that tell immune patrols what is happening inside. When a cell is infected or has become abnormal, those fragments look different, and immune cells respond. T cells are particularly important. They seek out cells presenting unusual fragments and trigger them to self-destruct. Other immune cells, like macrophages and dendritic cells, help by presenting warnings and coordinating the response. In many cancers, simply removing inhibitory brakes on these cells unleashes strong anti-tumor activity. In prostate cancer, that approach often underperforms, and the reasons are now clearer. One reason is that tumors are skilled at changing the signals on their surface, so they are less likely to be flagged as dangerous. Another is that they release chemical messages that quiet nearby immune cells. Over time, the immune response around the tumor becomes exhausted and less responsive. Some immune cells that should be active become tolerant. Others are recruited into roles that, unintentionally, support the tumor. When people say prostate cancer is a cold tumor, this is what they mean. The local immune environment is inactive or misdirected, rather than energized against the disease. Researchers have identified specific patterns in this environment that matter. Certain signals on tumor cells function like an access badge that tells T cells, in effect, do not engage. When that badge is blocked by a therapy, the T cells can recognize the tumor and act. This isn't magic. It is a direct consequence of restoring a clear conversation between immune cells and the cells they are meant to survey. In practical terms, blocking those inhibitory signals can convert a quiet, ineffective immune response into one that is focused and sustained. The physical setting of the tumor also plays a role. The tissue around an advancing prostate cancer often becomes dense and stiff. That stiffness is not just a byproduct of growth, it changes how cells behave. Dense tissue can limit the movement of immune cells into the tumor and can amplify molecular signals that suppress immunity. Think of it less as a metaphorical wall, and more as a measurable property of the tissue that affects the way cells communicate and migrate. Interventions that alter this microenvironment by reducing that stiffness or changing the signals it supports can make it easier for immune cells to reach and act on the tumor. A second feature involves macrophages, the immune cells that normally engulf threats and help coordinate defenses. In the vicinity of some prostate tumors, Many macrophages adopt a pattern of behavior that is less aggressive and more supportive of tissue remodeling and growth. They release factors that help tumor cells survive stress, and they can dampen T-cell activity. The encouraging development is that this pattern is not fixed. With the right cues, macrophages can shift back toward an anti-tumor role, increasing their ability to present danger signals and supporting a more effective T-cell response. Therapies that nudge this shift can amplify the effect of other treatments. These insights help explain past results. Immune checkpoint therapies that work remarkably well in cancers with highly visible abnormal signals struggled in prostate cancer, where those signals are muted. The microenvironment is restrictive, and supportive immune cells have been redirected. Now, combination approaches are being designed to address all three issues: remove inhibitory badges on tumor cells, make the tissue environment more permissive to immune infiltration, and encourage macrophages and other cells to resume their defensive roles. When these strategies are aligned, the total effect is larger than the sum of the parts. Consider a patient who has already been through standard treatments. Imaging shows persistent disease. Lab results suggest the tumor is active despite prior therapy. Instead of repeating the same approach, the plan shifts. Use a therapy that blocks inhibitory signaling on the tumor, pair it with a strategy that supports T-cell activation, and add an intervention aimed at improving immune cell access to the tumor site. The early goal is not an instant cure, but measurable changes. More immune cells reaching the tumor, stronger markers of immune activation, and, over time, a reduction in tumor burden. Clinical teams monitor closely, adjusting as needed. It's careful medicine, and when it works, it reflects the immune system doing the job it was designed to do. If you have a thought or a question at this point, add it in the comments. Community discussion helps people facing similar decisions, and your question may be exactly what someone else needed to ask. The broader impact of this shift is practical. For years, patients and clinicians have viewed immunotherapy in prostate cancer with caution because response rates were limited. By targeting the specific reasons for that limitation, signal suppression on tumor cells, restricted access in the tissue, and misdirected immune support, those responses can improve. Not every patient will benefit in the same way, and careful selection remains essential. Tumors differ. Genetic drivers differ. Prior treatments matter. But clinical trials are increasingly designed to match combinations to patient profiles, and that alignment is where progress accelerates. Education around this topic matters as much as the drugs themselves. Patients who understand the basic roles of T cells, the significance of inhibitory signaling, and the importance of the tumor microenvironment can have more productive conversations with their clinicians. They can ask whether a trial is available that targets these specific mechanisms. They can understand why a combination is recommended instead of a single drug. They can recognize that no change on a scan after a few weeks may still be consistent with a therapy that is gradually reorganizing the local immune response. It is also reasonable to talk about safety. Any therapy that activates the immune system can carry risks: inflammation in healthy tissues, fatigue, changes in lab values that require monitoring. Experienced teams anticipate these effects and manage them with established protocols. The point is not that immune-based combinations are risk-free. It is that the risks are known, often manageable, and balanced against the potential benefits of a more durable response. As always, decisions should be individualized with clinicians who know the specifics of a case. Another useful perspective is prevention and early detection. While this narrative focuses on treatment advances, basic steps such as discussing screening, maintaining a healthy weight, staying physically active, not smoking, and managing chronic conditions remain important. They do not replace treatment when cancer is present, but they contribute to overall health, improve resilience during therapy, and may affect outcomes. Health is cumulative. Small, consistent behaviors support larger medical interventions. Families play a crucial role. Understanding why a loved one might be offered a combination therapy rather than a single medication can reduce uncertainty and stress. Knowing that part of the goal is to make the tumor more visible to the immune system and to improve access for immune cells can make scan results easier to interpret. Being ready for more frequent monitoring at the start of a new approach can help with planning work and caregiving. Clear communication among patients, families, and clinicians is as important as any individual drug. On the research side, momentum is building because teams are sharing data more effectively. As patterns emerge, who responds and why, what biomarkers predict success, which side effects are most common, therapies are refined. The field is moving away from a one-size-fits-all model toward strategies that are adjusted based on tumor features and immune profiles. Progress may look incremental from the outside, but in aggregate it reflects a change in how this disease is approached. Not just attacking the tumor directly, but re-enabling the body's own surveillance and response. When clinicians talk about turning a cold tumor hot, they are describing a measurable change. Biopsies may show more T cells inside the tumor. Blood tests may reveal signals of immune activation. Imaging may capture a slower growth rate or shrinkage that follows the immunologic changes. None of this relies on myth or miracle. It reflects processes that can be observed and quantified. The story here is not that prostate cancer suddenly becomes easy to treat. It is that targeted changes in key steps can make a resistant disease more responsive. If you want updates on this kind of practical, evidence-based progress, consider subscribing and turning on notifications. It ensures you see future explanations that can help you follow new options as they become available. The road ahead includes many questions that researchers are actively exploring. How long should combination therapies be continued once a response is achieved? Which sequences of therapy produce the most lasting benefit? Immune activation first, or after another modality reduces tumor size? Can non-invasive imaging be improved to track immune activity in real time so that adjustments can be made sooner? Each answer moves the field forward, even when the first attempt is imperfect. The precision of the questions is a sign that the core ideas are sound. For those living with prostate cancer now, the message is balanced and concrete. There are reasons to be cautious about claims that sound too simple. There are also strong reasons to be encouraged by approaches that address the known barriers to immune effectiveness in this disease. Ask your clinician whether trials are open that combine inhibition of suppressive signals with strategies that improve immune access and function. Ask what biomarkers are being tracked. Ask how success will be defined and over what time frame. Good teams will welcome those questions. It is worth saying plainly that no video can replace personal medical advice. Each case is unique. What is possible here is understanding, a clearer picture of why the immune system has struggled in prostate cancer and how that is changing. Clarity supports better decisions. It reduces confusion when test results arrive. It helps families align around a plan. If this explanation helped you see the subject more clearly, share it with someone who might also benefit. Awareness creates better conversations, and better conversations support better care. In closing, the central idea is straightforward. Prostate cancer has used several tactics to avoid the immune system. Dampening recognition signals, shaping a tissue environment that limits immune access, and redirecting helpful cells into unhelpful roles. Newer strategies aim to reverse those tactics simultaneously. When that happens, when recognition is restored, access is improved, and cellular support is redirected, the immune system has a better chance to do what it does best: recognize abnormal cells and remove them. That shift does not promise guarantees, but it represents real progress and a more informed path forward.